Hi, how are you? Good morning. Hey, Krista. Hey, Sally.
Morning, how are you?
Good, how are you doing?
Good, thanks.
Awesome.
Good. Sorry, I was on mute. Good morning.
Morning
Morning.
or afternoon, wherever you may be. How's everyone's week going? Springtime, hopefully, is here for everybody.
Hi, Dr. Clements.
Hi, Don.
I snuck in the back door here, so is it okay if I just work in the background?
Absolutely.
Thank you.
Good.
We'll probably just give it like a minute or two as people are trickling in. And this is going to be recorded if that's okay, so we can always send it out after.
Perfect.
Which is how a lot of people actually like to consume things as well. Amazing. Okay, yeah, let's give it just a little bit as people join. How was everyone's weekend? Any fun plans? Did you do anything nice for spring weekend? Relaxed.
I think so.
Good. Took care. Okay. I'm letting people in. There we go. All right. Okay. Well, as people join, I guess we can kick things off since I know we only have 60 minutes. I just want to briefly say I'm Kate. I'm a program manager at KidsX. I work for Children's Hospital Los Angeles Innovation Studio. And one of the programs we run, KidsX, is a consortium model that essentially connects startups and health systems together to work more collaboratively. But through that mission, we have an ultimate desire to accelerate innovation efforts across children's hospitals more broadly to scale innovative solutions like the ones that Children's Hospital, Children's Mercy Hospital is going to speak about. And so I just want to thank you all for being here and learning more about some of the innovative work they're doing and how you all at other organizations can learn from them and collaborate with them to accelerate efforts, particularly in the diabetes management space. So I will turn it over to, I think it's you, Dr. Clemens, and your team to kind of describe and discuss the details of the work they're doing and the opportunity for the other folks on this call to kind of engage and join in.
Absolutely. Thank you very much. I'm going to share my screen.
Awesome. Let me know if you need any. Perfect. I can see your slides.
Okay, so I'm going to talk about an initiative that we created about 2 years ago called the Rising T1de Alliance. And we think that we are at the stage now where we could start to disseminate the solutions that we have created to other interested parties. And the way I would position this is that we are trying to solve some of the most difficult problems in diabetes care, and we have designed some solutions from clinicians for clinicians. So about me, I am a pediatric endocrinologist and a professor of pediatrics here in Kansas City at Children's Mercy Hospital and the University of Missouri, Kansas City. I wear a couple of hats at the hospital that you can see there. So what do we have? Well, what I'm going to talk about today are the two main features of our platform, which are a diabetes data mart and then the MyCare mobile app for diabetes, specifically the mobile app modules for diabetes, which I will talk more about later because we think they're portable. So if your hospital has its own application, we think that these modules could be ported. And then I'm going to talk about the implementation expertise we think we've acquired for remote patient monitoring. We're quickly becoming experts in how to integrate a new program like remote patient monitoring into our clinic flow. And we are actively working now to become experts in the billing process for remote patient monitoring. So why did I start down this path? Well, this is a pretty infamous graphic now, published by the T1de Exchange. We are member center of that from 2011 to 2019 or so. And this was 84 centers doing health outcomes research in type 1 diabetes, pediatric and adult, for just about a decade. And what this graphic shows is that blood glucose control, as measured by the hemoglobin A1C biomarker, tends to be significantly higher than our target of 7%, which you can see down at the x-axis, across the lifespan, but that young people are particularly struggling when you compare them to individuals of other ages. Not only are their A1Cs higher, but they get worse after they're diagnosed. And they peak at around 9 on average. This is from age 8 to 18, that there's a rise in A1C. And it takes until about age 30 for that to come back down. And basically the result of that is most of the lifetime risk of diabetes-related complications accumulates on our watch in pediatric centers. And I think this is a critically important public health problem for us to solve. If the costs of diabetes are high, the costs of treating the complications of diabetes are astronomical. So we also know that if we look at outcomes in the form of how many of our patients are meeting A1C targets, that they vary significantly between developed nations and between centers within a nation. So on the y-axis, you'll see that we're counting the percent of patients with an A1C less than 7.5%. That's because this work was conducted in 2017, just about the time that we were changing our standards to try to achieve an A1C of 7% rather than the historic target of 7.5%. And what you can see here for the US is that we're not doing very well compared to some other developed nations, particularly in Europe, where they're getting a much higher proportion of patients into the target range. And from center to center, there's like a twofold difference, from 15 to 28% in the proportion of patients that individual centers are getting into the target range. So this inter-center variability, I think, is really problematic, and we can do better. So what's the problem with trying to move the needle on glycemic control, quality of life, and other patient-centered outcomes in diabetes? The problem is that they only spend 0.03% of their waking hours in clinic with us, which leaves us precious little time to actually make a difference. The current paradigm is 4 clinic visits a year, which I find incredibly limiting for not just diabetes, but any chronic disease management. So what is our solution? Our solution is a platform that includes a data mart, which I will show to you, that integrates data from many sources, that includes dashboards that we have built and the ability to rapidly produce new dashboards that will empower population health management. It includes a patient engagement user interface in the form of the MyCare mobile application and specifically the diabetes modules to drive patient engagement. And it includes a toolbox for implementing remote patient monitoring and layering a variety of digital and behavioral therapeutics on top of those remote patient monitoring visits to try to move the needle on clinically important outcomes. So you can see essentially it connects medical record and device data, and patient-reported outcomes data. It empowers teams to visualize risk in their clinic. It helps clinics to engage youth with diabetes and their families by creating a diabetes clinic in the pocket. And I think it acts on some of the most challenging problems facing clinics today by helping a center have a sort of air traffic control tower approach to their population and knowing who to connect to which intervention at what moment. So I just want to emphasize again that the solution was created by clinicians for clinicians. to understand where it was developed. Our team is located at Children's Mercy Kansas City and the Children's Mercy Research Institute that you see featured on the right. And you can see that we are a distributed healthcare system with sites across the states of Kansas and Missouri. So what is the Diabetes Data Mart and what do we hope to achieve with it? Well, our first goal was to automate data collection and sharing. We wanted to create standardized, repeatable reports and visualizations that could help drive our learning health system within our own organization, which I affectionately call the Rapid Learning Lab, to empower cohort selection for interventions and studies. And one goal was to get to the stage where we can process data once and use it many times, because I have found the data ecosystem at hospitals and healthcare systems to be incredibly inefficient. And I say that not just in my role at Children's Mercy, but I was the chair of the T1de Exchange clinic registry, those 84 centers for 3 years. I also am the data science lead for the T1de Exchange Quality Improvement Network. And all of the hospitals are expressing the same concerns about data accessibility and data use at their organizations. So why a Diabetes Data Mart? Well, because I believe that we need a connector or a middleware that exists between the clinic, or you could say the EMR, and the outside world. A lot of existing solutions in the marketplace try to connect external data directly into the EMR. And I've really been scratching my head for a long time about why they're trying that tactic, because I think that, first, the EMR is an incredibly complex beast. And there are a lot of policies and regulations that organizations wrap around the EMR that make it difficult and very time consuming to try to move data directly into the EMR. So I think it limits scalability. I think a middleware solution allows you to move data adjacent to your institution and then to take the time that you need to integrate into the EHR from there. So think of many pipes coming into the institution, into the middleware, and then one pipe leading to the EMR. The other problem is that existing solutions typically only offer limited access to external data. So for instance, a lot of the glucose devices and the companies that manufacture those glucose devices, they offer you 13 variables off of those devices that are summary metrics. You can't get anything that isn't offered, and you can't get to the raw data very easily to calculate your own metrics. The other thing that the Diabetes Data Mart does is it handles functions not performed by other solutions. So we wanted to get to the point where we could get in front of clinically important problems by predicting them. So it allows us to manage predictive analytics and how to present that information to clinicians. It helps us to integrate that and other information into population risk dashboards. And these are dashboards that I want to tell you we can create in the order of weeks, not months or years. So we can stand up a new dashboard, and we've stood 2 of them up since January 1st. We also have the ability to create a sort of air traffic control tower where we can understand patient flow through our care ecosystem from a number of different perspectives, not the least of which is understanding who's in a special interventional pathway or a clinical trial or another research study right now. It enables a learning health approach because, again, we can focus our attention on individuals at risk so that we can try to mitigate that risk. And it reduces friction for research, and I'll show you how in a moment. So this is the sort of architecture or the schematic for the Diabetes Data Mart. You can see on the left that we're using APIs or application programming interfaces to connect to a variety of resources within the hospital and external to the hospital. So within the hospital, we're connecting to the electronic health record. We're connecting to an e-survey tool. Many of you may be familiar with REDCap. You could substitute any e-survey tool here that has an open API that allows you to move data from one software package to another. we're connecting to all of the major diabetes self-management device manufacturers and the aggregators for those diabetes device data that bring together data from multiple manufacturers. We have a connection to Garmin Fitness Tracker. We could stand up a connection to Fitbit or to another tracker as well, quite easily. We are working now to integrate the MyCare app that I will mention later into this platform. And you could imagine other things that you might want to integrate. The point is that we can create custom APIs. And the first thing we do is we bring it into a very unstructured environment. For those of you who are familiar with databases and data tables and normalized data, well, dropping things into a data lake means dropping them into their very messy, sometimes unstructured, sometimes structured format that comes directly from the source. So that's our ingestion layer. And then we go through a series of data cleaning, data transformation, and standardization exercises, and we can create an operational data set. And this is now a normalized data set. It's a data set that has structure, it's in data tables, and it serves our operational or service layer. Imagine that this is the section that our population health dashboards are feeding off of. And then finally, we have designed an approach so that we can take the operational data, and if you had an IRB approved clinical research data repository, you could strip away the 18 HIPAA identifiers, and you could dynamically pull data into this research repository section, or you could statically do so and mirror everything in your operational data set into a de-identified repository. You can then lower your burden for conducting clinical health outcomes research, which I think is very important. And then all of this together can feed into population health visuals, can feed data back into the electronic health record. So we're working with our medical informatics right now to build a Smart on Fire app that will push some limited but important information back into the EHR. And you could send data out to external partners. So I'm going to tell you about a couple of things that we've done with regard to population health dashboards that I think are pretty fun and are going to be incredibly useful. So the first is, my colleague Joyce Lee at the University of Michigan and my colleague Sarah Carruthers at Cincinnati Children's, where Don is from, they and others put together this health record assessment of 6 pediatric type 1 diabetes self-management habits and their associations with glycemic outcomes. So the habits you can see in the abstract below are, does the individual check glucose at least 4 times a day or use a continuous glucose monitor? Do they give at least 3 rapid-acting insulin boluses per day at meals? Do they use an insulin pump? Do they deliver their insulin boluses before the meal or halfway into the meal? Have they reviewed their glucose data since the last clinic visit? And have they changed their insulin doses on their own since the last clinic visit? And I won't get into the details about why these habits are so important, but they map on to the 7 pillars of diabetes self-management from the ADCES, that organization of diabetes educators. But what we did is basically take this paper, and in 2 to 3 short weeks, we were up and running with a new population health dashboard that allowed us to look at all of our patients and at their latest visit, ask whether they were performing any one of these 6 habits or not. And so we could get a simple understanding for how frequently this habit is being missed, and that's really helping us to identify an opportunity for intervention. You can see that if we wanted to analyze these habits among different groups, we could analyze among different racial groups, among different insurance class groups, and among different age groups. And we're not finished yet. There are more segmentation tools that we plan to build into this. And, if we want to understand, how many people across our clinic, where we provide care for about 2,400 youth and young adults with type 1 and type 2 diabetes, are engaged in each habit, we can see what the number of individuals at individual clinic visits. So this is a patient visit. How many of them were performing 0, 1, 2, 3, 4, 5, or 6 habits. And we can see what the average habit score is down in the lower right. So we can see that we have a long way to go to try to improve these habits. And that's very important to do because the authors of that paper I just showed you have shown that there is basically a linear correlation between the number of habits you engage in and the reduction in your A1C all the way out to 6 habits. The other research that we have engaged with recently comes from my colleagues at Stanford. So Priya Prahalad is in the T1D Exchange network with me. David Moss is a longtime colleague, and Ramesh Johari is a healthcare management engineer. And they published this paper that does something really unique for diabetes. It allows people to look at population health continuous glucose monitoring data in a way that will help clinicians and diabetes educators address population health in a precision way. And so what we did is we basically took their dashboard, and again, in just a couple short weeks, we had it implemented in our data mart. And we're able to identify these risk categories that you see up here on the left. The number of individuals who have greater than 1% of their time with an extreme low blood sugar, which is very dangerous. Number of individuals who've had a large drop in their time in range. So that's a quality metric. How often are people's blood glucoses between 70 and 180 milligrams per deciliter? How many are just already having a low time in range? How many are missing data so that we can't evaluate? How many have extreme highs, and how many don't have any alerts? And this is just a sample of data from 1 week. And you can see that we get all these metrics going across the bottom. For the first line, the time in range is 76%. We can see that there are some metrics going off to the right. We've blinded the bolus score column because that's our own addition to this dashboard that came from Stanford. And off screen, what you can't see is that we've developed a new predictive model for time in range over the next month. And we're not showing that yet either. We're doing some user design work, and then we will release those into this dashboard for our clinical teams to use. We can also see an individual's detail, so we can see how an individual's time in range has changed over time and track it longitudinally to see if they're getting better or getting worse. So those are just 2 examples of population health dashboards that we have implemented. We've been able to move very fast from research publication to implementation. I'm going to now talk about a couple of things we're doing that rely on data in our data mart that help us get in front of clinically important problems. So the first is that we have started to implement machine learning at Children's Mercy. We assume that our population has a diverse risk for any given outcome. In this case, admission to the hospital for diabetic ketoacidosis that you see at the top, and presumably diverse responsiveness to any treatment that we could put in front of them. And you can see the types of treatments, at least the way I conceptualize them, in the lower right. So you can see the primary treatments for diabetes might be drugs, biologics or devices, or some combination of those. So maybe they're on one kind of insulin, continuous glucose monitor, and an insulin pump. But what doesn't get as much attention in diabetes centers are the behavioral and care delivery interventions that are often now available through digital therapeutics in the form of mobile apps or web apps to help drive quality care. So the idea here is if we could risk stratify the population based on a predicted outcome before the negative event happens, then maybe we could try some stuff like remote patient monitoring or remote patient monitoring plus some digital or behavioral therapeutic to see whether we can move the needle and to learn very rapidly whether we're moving the needle with that tool. So the data mart, has really enabled AI in production because we can import the results of these models and present them in our population health dashboards. We've not stopped with predicting hospital admissions for DKA. We're also predicting those individuals who will have a significant rise in their A1C over the next 90 days. And I'll show you just a little bit of information here in a moment about both of those models. For the prediction model for rising A1C, if you want to nerd out on the stats a little bit, we developed the model with youth 9 to 18 years old diagnosed for at least 6 months. We developed a random forest model. It uses data from our medical record, including free text notes. It also includes the self-management device data that every diabetes center would love to get locally, but are so difficult to get. We have cracked the code on getting. And you can see that we have a positive predictive value of about 56% for identifying an individual who will have a rise of 0.3 or greater over the next 90 days. Remember that graph I showed you at the very beginning, that graph that showed a mountain on the left, sort of like Mount Kilimanjaro. These youth, a fair number of them are having very significant rises, but those rises don't happen over a 90-day period. They happen repeatedly every 90 days until they have such a high rise that they're at the top of the mountain. Well, if we can get in front of that, then we might be able to do something about it. So this positive predictive value gives us between about a 1.6 and a 2-fold enrichment of the population for the risk of this outcome, which we thought was good enough to go to the court with, if you will, and try some things to see whether we could move the needle. The other model that our Diabetes Data Mart helps to enable is one that predicts hospital admissions for diabetic ketoacidosis. Again, if you want to nerd out, I've given you just a little bit of information about it here. This is run on individuals diagnosed for more than 3 months at any age. It is what's called the long short-term memory model, which simply means if you look at the right-hand side, that we can not just use recent data to make the prediction, but in the sort of green colored boxes, you can see 90-day windows. And this model has memory. So whenever it's trying to predict the risk for the next 180 days, it reaches back not only to the previous quarter of information, but it also reaches back to all of the other historical quarters and carries that information forward in a way that helps it to really refine its prediction. So the details are largely irrelevant. The point is we're predicting hospital admissions for DKA, and we're doing so pretty well. Here's what our stats look like. Precision, that middle number in the table, is the positive predictive value. And when we look at a rank ordered list of our top 80 patients by risk for hospitalization, you can see that at the top of our rank ordered list, we're 100% right. The top 10, we get it right every time. If you dive deeper down into the list, we're right over half the time. So for the top 25 each month, we're making this prediction once a month. And if we consider the entire list of the top 80 individuals, we're right 33% of the time. So what do those numbers mean? Well, if I told you that about 5% of our patients are admitted to the hospital every 6 months, you could easily see that we are risk enriching the population by somewhere between 6-fold at the bottom of the list, the 80th person on the list, and 18-fold at the top of the list, where we're 100% right. So that's a really robust enrichment of risk. And what that means is that when we identify somebody that we want to intervene on, the chances are pretty decent that they're going to be admitted to the hospital, and decent enough that we won't feel like we're wasting our effort if we intervene on anybody on this list. So how are we intervening? Well, we've developed some experience now in implementing remote patient monitoring across our institution. And we're using interventionists, clinicians, diabetes educators. We're using a video platform or the plain old telephone. And we're using basically a checklist of topics for discussion to try to drive these small, bite-sized 12 to 15-minute visits. And these can happen as frequently as weekly. We found, if I can draw your attention to the top row, in 100 individuals who were predicted to have a rise of A1C of 0.3 that you can see in the middle column, that we were actually able to reduce that A1C rise to a negligible amount with remote patient monitoring. That's without adding anything else besides having a few phone calls between clinic visits or a few video visits. So we don't want to stop there. So we've really thought about how to use our data mart and our tools to drive the pillars of diabetes self-management and increase engagement with them. So you can see on the left what those pillars look like, and on the right, you can see just a few different strategies that are in the literature that we think may move the needle on engagement with the pillars of diabetes self-management. And these are the kinds of things that we're layering on top of remote patient monitoring to test as we speak. So in summary, the data mart enables data distillation. It helps us get to insight and action. So now I want to switch gears to the second vertical in our product lineup, if you will, which is the MyCare for Diabetes module, which is, we think, it's based on some user-centered design. We're going through usability testing every week, and it's fulfilling real patient needs. So we identified the needs that patients declared as learning how to care for my diabetes, learning how to share my care plan with other caregivers besides my healthcare team, integrating my care plan seamlessly into my daily life, and putting the clinic in my pocket so that I have easy access. So this is what we've got. This is just a screenshot of front page of the MyCare app. And again, the MyCare app is I would say, sort of a Swiss Army knife of apps, in that modules for different clinics with treating different chronic health conditions can be layered into it. So I'm going to be specifically talking about the diabetes modules today. And these modules are addressing educational and self-management resources. They are helping us to deliver digital therapeutic interventions, and they are helping us to onboard patients to other interventions that exist outside of the MyCare app. And I'll explain a little bit of what I mean in a bit. I'm going to run through a few of these slides really quickly because I don't want to focus on the details of MyCare app, but I want you to just get a flavor for what it is. So, it's a platform to connect families to education, intervention, content, and off-platform interventions, as I mentioned. The user design has been thought out very well. In the health tab of the app, youth with diabetes or the parent can enter the child's insulin plan. We hope in the future to be able to port this directly from the medical record into the app from their last clinic visit. And then an insulin summary will be available on the screen. For sick day management, we have designed algorithms that walk our young people and their parents through what to do step by step. So you can see here some of the steps that they would take if their blood glucose was less than 70 when they checked it, and they can even set reminders to recheck in 15 minutes, which is the most common standard for rechecking after treating a low blood glucose. If they have a high blood glucose, this can create a risk for diabetic ketoacidosis. So we want them to check their urine or blood ketones. And you can see, again, we walk them through not just what to do, but you can see the visual in the left two panels of what the urine ketone test strip looks like and how they should interpret it. So it's providing education, and they don't even realize that they're getting education. And then if they're starting their journey on their sick day, not with a blood glucose value that is out of the norm, but with urgent symptoms like not being able to keep fluids down or vomiting, or their child is unconscious, you can see there's an immediate link to emergency contacts. And then there's also some guidance that walks them through what to do for those symptoms. And then a second feature of the diabetes modules is the diabetes passport. And parents were really excited about this idea. They actually pitched it to us, which would be helpful for babysitters, coaches, and other types of caregivers in the child's life to know what the important details of their diabetes management are, including who to contact right there in the mobile application. And then the third feature is a set of learning journeys. So learning journeys are basically a string of resources within the app. They're multimedia content. They can be videos, text cards, they can be survey links, etc., that we string together and we say, this string of resources makes an interventional pathway. And we're not just stringing together any old thing. I do a lot of work with a pediatric psychologist, Dr. Susanna Patton in Florida, and other colleagues. And these are deeply theory-based and evidence-based interventions that we are working to implement into the platform. And the idea here is that we could not just create one, but we could create 2 or 3 or 10 different interventions on this platform, and the individual could be prescribed that interventional pathway, and then they could go through it through a series of weeks with the app. We also think that this can help us to onboard people to new interventions. So, showing you a quick clip there of what some of our videos look like. Hopefully you could see that. We animate videos using a tool called Vyond. And even if an intervention is not housed on the MyCare app, we think that we can start the patient's journey through the MyCare app, which solves a very important problem, which is that we have many, many patients and not so many staff to onboard people to those interventions. So this helps us to really scale it. So in summary, we designed our MyCare app to be multifunctional, but some have already asked previously, what if my hospital has its own app? We've also designed our MyCare diabetes modules to be portable, and our team has the expertise to explore integration of them into other apps. And if you have your own app with your own diabetes care features, we could also integrate data from your hospital's app into our data mart, which you can see at the lower left here. So the final thing that I will say is that we are bringing expertise in QI methodology. So we understand, the plan, do, study, act cycles, the toolkit used for QI, which you really need if you're going to try to introduce a variety of care delivery interventions into your care ecosystem. We've developed expertise in remote patient monitoring. We are developing expertise in how to bill for remote patient monitoring at our institution, and we hope to be able to share that knowledge widely. So what I'm really describing is the third vertical here, which is the sort of consulting expertise we have around implementation of new programs. And then we're developing training manuals, intervention manuals, data mart how-to guides, change packages, and something we call Rising Tide reports that help people learn what we've learned through our own implementations. And you can see our website down below there. So the significance we've designed for diabetes. Diabetes is a prototypical pediatric condition. We don't think that these tools are going to stop at diabetes. We think that this general approach of a data mart that serves as a connector between the health system and the outside world, and a patient engaging user interface like the MyCare apps diabetes modules will be generalizable to all pediatric conditions in the future. So to end, I've got a couple of asks of those who are on. One is, if you are interested in anything I've shared about today, we would love to schedule time with you so that we can learn more detail. You can learn more details about our verticals, so that you can teach us about additional features that might be required to meet your needs, the problems you're trying to solve in your clinic. That we could explore the potential for implementation options at your institution, whether that's for clinical care, research, training, or workflow improvement. And during this meeting today, we'll have about 20 minutes left. I'd like to ask whether any of you are doing this kind of work, and we can learn from each other, and what you can share about your needs and your barriers. And you can see in the lower right that I think that we have hit all of the checklist items on the KidsX wish list for innovation ideas here. So these are some of the folks who are involved. I couldn't do it without our very strong team. And you can feel free to email me at that email address. I'll let that linger up there for a few moments, and I'm happy to drive some discussion.
Thank you so much for presenting. And thanks to everybody who's on the call. Yeah, I'm really curious as well if what kind of work in the space other people are doing at their organization, and or just things that resonated or they're interested in from what they heard from yours. So feel free to either unmute yourself or put stuff in the chat if anything comes to mind.
Mark, this is Jonathan from Arkansas Children.
Yeah.
How does this integrate with Epic, if at all?
Yeah, so we're, as you may know, a Cerner shop, but what we are working on right now with our medical informatics team is the creation of a Smart on Fire application that would allow us to use standards that are common to Cerner and Epic and all the major electronic health record systems, so that there could be one pipe. It doesn't matter what your EHR is. Now, you'd have to do a very small amount of work with your medical informatics team just to create the tables for the data to land into. But the Smart on Fire app will send data in through recognized standards. So it doesn't matter essentially what kind of EHR you're on. We should be able to connect to it once we've got that Smart on Fire app built.
Thanks.
Yep. I know Don's got a question. Don thinks about these things all the time.
We also have been working around with some predictive analytics and applications. So I did appreciate what you're doing there. I just want to say this: I'm extremely impressed with the integral approach that this program has brought together. When you think of the clinical science, in the operational science, and even improvement science that you mentioned, all coming together through the use of these tools and then leveraging off of that integration. Incredible potential here. So I appreciate your hard work. Thank you.
Yeah, well, that's, Don, that's why we think that these tools are ready to export to other centers that are interested in using them. And we think that we're at a stage of maturity where we're approaching market readiness, the ability to license and export this to help people implement these tools at their own centers. Because my mission at the end of the day is to try to help more people with diabetes. And if I step back a bit in my training and take off my diabetologist hat and put on my general pediatrician hat, we want to help all kids. right, with chronic disease. So I think that we're all here for the same reason. And what has driven me in this work and all the work I've done up till this point is a desire to try to accelerate what we can accomplish. We all have only a limited amount of time on this planet in our working careers to try to leave the field better than we found it. And I feel like that's sort of a precious commodity, that time. So we want to use it as wisely as we can.
Thank you. Anybody else working on similar or similar initiatives are kind of interested in discussing more about this one? Curious from like Melanie or Todd or Sarah.
Hi, I'm Sarah Lyons at Texas Children's Hospital and Baylor College of Medicine. We are very early in starting some remote patient monitoring. And so I think Mark's may be familiar with some of the kind of the work that we're going to be starting, but so this is very helpful to learn, Mark, what you've been doing and all your amazing work. And so you're obviously miles ahead of us, but we're trying to look at how do we use diabetes platforms to be able to remotely view some of our highest risk youth or those who may be new to technology that may need additional support. How can we support them starting in a pilot situation with a very small number of patients?
Yeah. And you know, Sarah, that, Rona and I have been communicating a lot about this bilaterally, right? What's going on at the Children's Mercy. And I think one of the questions perhaps for you to take back is there anything that we're doing that be beneficial for implementation at Texas Children's, because we want to share seamlessly, and then vice versa, right? Are you guys developing any tools?
I love the collaborative nature of diabetes and how we through especially with the T1de Exchange able to share that. So we definitely would love to have more conversations with you about what you're doing and then share our data, and then also think about our we have a predictive model that's a little bit more static of the predicting risk for diabetes that was developed maybe 5 years ago or so. That's been refined, or as we think about how do we refine ours, learning at yours, and then potentially does our data help support your models, or how do we learn from each other? So I think that's the really exciting part about having all these large de-identified information. Can we build upon our models just to improve care for youth with diabetes around the United States and not just our particular site?
And this is Melanie, also from Texas Children's. Thank you for chiming in for Texas Children's. I just want to add to that. I think that some of the maybe barriers that have come our way is that EPIC is such a robust model, and that we tend to have an EPIC first mentality of how can we use the tools in front of us, but also recognizing that they aren't meeting all of the needs as your tool has outlined that our families and patients need. And so I'm really interested in seeing how more of the platform level, which is what we've been talking about a little bit more recently, can help us achieve some of that. And I think there were some really neat features that would be just indisposable to our families that we'd love to learn more about.
Yeah, happy to talk further about that.
Thanks.
If there are no other questions, we can always wrap, and we'll send out this recording. And yeah, if Children's Mercy team, if there's, I know that slide with the asks, if there's any kind of specific ask, we can send that out in the follow-up as well. But super appreciate you taking the time to share more about what you're doing and kind of extend an olive branch to other organizations who might want to collaborate and kind of expand on this work. So thank you.
I want to thank you for hosting and everybody for taking time out.
Of course. And also just for other KidsX champions, we have our kickoff week 0 to meet the cohort next week. So super excited about that as well. And yeah, still should be on your calendar, but if it's not, you know where to find me. So hope everybody has a really lovely rest of their day and week. And we'll see you all soon.
Bye-bye, everyone.
Bye.